2024. There we go. Project ECHO Dementia session. We will, as is our custom, kind of run through our standard agenda. So let's do some quick opening notes and reminders. We haven't done introductions in a long time, and I think we've got the luxury of time. So depending on our audience size, maybe we'll do that. That's always fun. And then we have the great good fortune of Dr. Jennifer Gatchell, who will be talking to us about mild behavioral impairment, or talking with us in the recognition and treatment of dementia syndromes. That should be syndromes, type on my part. A couple of quick reminders. If you are joining from a phone, it's kind of hard to do, but if you're a nondescript title, if you could rename yourself first and last name and clinic if possible, just so we know where you are and who you are, so we can keep track for CME purposes. And it looks like there's still some folks joining us in the waiting room. Thank you, Sammy, for letting them in. Just a reminder for muting your microphone when not speaking and practicing saying your name when you unmute so we can continue to get to know each other. If you have the capacity, it's always lovely to see your smiling faces. Have your video on. Understand that that's not always a possibility. And if there are scenarios where there are multiple of you in the same location, if you could put everyone's name in the chat, again, just for housekeeping, record-keeping purposes. We are accredited for CME. If you are University of Washington faculty, staff, students, this is the process. Feel free to take a photo of that, but pretty straightforward. We'll put it up at the end also. We have about an hour after this ends to claim CME. For everyone else, we will do the usual format of keeping track, and Samantha will reach out to you if needed. Just some reminders about other resources. Our sister program, in a way, UW Project ECHO Geriatrics, which is on the third Friday of each month. Wonderful series. And some great resources around TBI, psychiatry and addictions, television health training series, some of our consultation lines, so for tricky topics like chronic pain and opioids, and also our Grand Rounds archives, including neurology and psychiatry. Some links there. And again, these will all be sent out in the slide deck after today's session. Some reminders for any of the clinical conversations, making sure that we are protecting PHI. We can always go back and edit it out. Done that in the past, but better to preventatively keep that out of the record. All of our sessions are recorded and available on our website. We did some math recently, and our top 10 sessions have been viewed over 4,000 times. I kind of forget that these things live on and reach people in different ways, but nice to have that as an archive as well. And we will indeed be sending out a quick post-session survey, as we always do. We already talked about CME. Our speaker today and our planning team have no disclosures. Anytime there are disclosures, there's a mitigation process for that. Here's our hub team, interdisciplinary, or cross-institutional, which is rare these days. And here is our community. And boy, this week has really got me thinking about the importance of community and the work that we do together. And it's so encouraging to see all of these zip codes out there across Washington for people who have participated over the last 5 years. It's nice to see some of those dots represented here today. So let's see. I'm going to hold there for a second and stop sharing. Yeah, let's do some introductions. Let's take the time to do that. So I'm going to go in order. So if you could unmute and say your name, the clinic that you're associated with, and maybe one thing you're looking forward to this weekend. How about that? So I'm going to start in my upper left with Samantha LaFontaine.
Hi, my name is Samantha LaFontaine, and I am the program manager for Project ECHO Dementia. I am this weekend looking forward to spending some time with my friends.
I forgot to introduce myself. I'm Chris Rhodes. I'm a professor of neurology and neuropsychologist here at UW and co-lead of this wonderful project. And I am looking forward to getting outside regardless of the weather. There's no bad weather, just poor clothing choices. How about Trang?
Hello, sorry. I'm just moving to a different room here. Hi, my name is Trang Lei. I'm a clinical pharmacist. I work at Overlake Senior Healthcare Clinic, and I'm looking forward to have some warm soup uh, with some friends. We have some friends over, so that's what I'm looking forward to, is to have some company on the weekend.
Sounds like a good combination. How about Dr. Demoto Riley?
I am Kimmy Demoto Riley, a cognitive behavioral neurologist at UW in the clinic, caring for people with atypical dementias such as FTD. So this talk today is very, very helpful. This weekend, looking forward to continuing to enjoy those fall colors, which are still hanging on.
All right, and Mimi.
Mimi Pattison. I'm a hospice and palliative medicine physician. And this weekend, I'm looking forward to the soup that is simmering on the stove as we speak and watching Gonzaga basketball.
Oh, also a good combination. 2 soups so far. We'll see how many we rack up throughout the intros here. How about Kathy Cooper?
I'm Kathy. I'm with Auburn Medical Center as a palliative care social worker. My passion here is to transform how the hospital acute setting cares for persons living with dementia while they're hospitalized. So I love joining on these calls, and it's been a really busy week. Sundays, I'm able to have a day to myself, so I'm looking forward to some quiet and silence this weekend.
That's and Carrie.
Hi, everyone. Carrie Rubenstein. I am a family physician and geriatrician over at Swedish, where I direct the geriatric medicine fellowship there and teach in the residency. And I know you guys are all going to feel bad for me, but I am heading to Kauai to speak at a conference this weekend.
Oh, I feel terribly for you. Hopefully you'll hang in there. How about Rhonda?
Hey, I'm Rhonda Holden. I'm the DOT in Kittitas County in Ellensburg. I'm a registered nurse, but I'm the senior leader for home health and hospice and our home-based primary care program. Dementia is one of our primary diagnoses that we care for hospice.
Outstanding. Lovely to have the Central Washington representation. Thank you. And Barack.
Hi, everybody. I'm Barack Gaster. I'm a professor of medicine, a primary care doctor, and dementia expert at the UW Medical Center, and I'm looking forward to a hike in the woods.
Carol.
Hi, Carol Heyman, family doctor, geriatrician. I work with Carrie at Swedish at the fellowship program, and I'm also the co-founder of a small startup dementia company serving patients with dementia called Veronica Health. I saw a recipe this morning for peanut butter miso cookies. So I'm going to give those a try.
Oh, very good. Right. Let's see. I think Karen Hayes is next.
Hi, everybody. Karen Hayes. I am the caregiver representative for our ECHO Dementia. I took care of my husband who had a presumptive Lewy body diagnosis for 8 years. And then on autopsy, turns out he had Alzheimer's, Lewy body, and vascular dementia. So that helped explain a lot about our journey. Anyway, I am a nurse practitioner, nurse midwife, but I'm not in a clinical role here. I'm just as a care provider. But because I'm a nurse practitioner, I really enjoy all the scientific stuff that comes forward on this ECHO dementia as well. So,
what are you looking forward to this weekend?
Oh, this weekend, I'm going to be clearing a tree that fell down in the last windstorm that narrowly missed my house, but is being a bit of an annoyance trying to get around.
Good luck. Wear a helmet. All right. And how about Sylvia?
Hi, everyone. I'm a behavioral neurologist working in Spokane, Washington for Providence, and I serve typically underserved population, wide variety of cases from rare to more common. And I always enjoy coming here every 2 weeks and listen to the lectures. I think I have a way to connect with people and a group in general. And this weekend, like many others have said, I'm looking forward to relaxing from a particularly stressful week, and potentially bake a cake, but we'll see where that goes. And exercise. I need to exercise. We'll see where that goes.
Very good. All right. Wonderful to have you here. And Lynn.
Hi, everybody. I'm Lynn Carty with Aging and Long-Term Support Administration. I'm in Olympia, and I'm here representing the Dementia Action Collaborative, who implements the Washington State Plan for Dementia. And I'm looking forward to getting out and enjoying the leaves before they all fall off, but I'm raking my leaves mostly before they're totally slimy. So then I'm going to enjoy my soup afterwards because I think I'll need it. So
Put another notch down for soup. Okay, Stephanie.
Hi everyone, I'm Stephanie Sirisithi. I'm with Navari Primary Care. I work in the geriatric population and I see my patients in their homes. I'm looking forward to a girls' night this weekend with some of my friends.
Excellent. Thank you for being here. Very good. Assad.
Hello. Can you hear me?
Yep.
I'm Assad Kozumi, Medical Director at Providence Place here in Washington, and I'm looking forward to some quiet time with family this weekend.
That sounds just about right. Thank you. And Hillary is next.
Hi, I'm Hillary Moore. I'm a new graduate nurse practitioner, and once credentialing is finalized, we'll be starting at the Swedish Center for Healthy Aging. And I'm looking forward to spending some time with my friends since I haven't seen many of them since graduation.
Well, welcome and congratulations on the new position. Thrilled to have you here. All right, Eileen, I think is next. Stepped away. Welcome back. Maybe. How about Janine?
Hi, everyone. I'm multitasking and answering a phone call about blood sugar, but I'm happy to be here. Providence Elder Place nurse practitioner in Seattle. I do house calls. And this weekend, I am looking forward to seeing different friends and not driving very much. That's what I do for my job.
Fair, fair, especially in Seattle. I appreciate that. Anne.
Hi there. Sorry, my camera's not connecting right now, but I'm a PA with the behavioral health team at Peace Health in Bellingham, Cedar Woolley, and I do consults for the primary care clinics, including the Center for Senior Health in Bellingham. And this weekend, I'm looking forward to doing a nice long run in cool temperatures.
Very good. All right, and Reza. One last try for Eileen or Reza, otherwise we can. All right, well, if you pop back on at some point, feel free to throw your info in the chat or say hello. All right, so with that, thank you all for doing that. It's been a long time since we've done introductions, and as much as it takes time, it's nice to know you all and who's out there. Okay, so it is my absolute pleasure to introduce Dr. Jennifer Gatchell, who is an assistant professor of psychiatry and geriatric psychiatrist at McLean Hospital and Massachusetts General Hospital. And she will be talking today about mild behavioral impairment, MBI, and the recognition and treatment of dementia syndromes. So with that, I will turn it over to you, Dr. Gatchell, and thank you again for being here.
Yeah, absolutely. It's my pleasure to be here. And let me share my screen. Let's see. Yeah, so again, thanks so much for the opportunity, for the invitation to present from Dr. Eisenberg and your entire team. And I was very inspired in reading a little bit about Project ECHO in preparation for this presentation about kind of the longitudinal component and just the broader Project ECHO. So I'm really excited to be able to attend this meeting today and to kind of hear how you all have collaborated around the topic of dementia care. Yes, I'm Jennifer Gatchell. I'm a geriatric psychiatrist. I'm engaged in clinical research related to neuropsychiatric symptoms in older adults, not only in the context of dementia syndromes, but also as risk factors for those who have aged with psychiatric illness, and also psychiatric symptoms that develop and emerge and may worsen in later stages of dementia, both in understanding neurobiology of these symptoms and approaches to management. So it's a little bit about me. This weekend, I'm definitely looking forward to some relaxation after a stressful week and some hot yoga. So let's see how that goes. But okay, so I'm going to talk to you. My presentation today is geared on mild behavioral impairment, but more broadly along the topic of psychiatric disorders versus early neuropsychiatric symptoms of a neurodegenerative disease, and how do we make this distinction. Within the broad context of my work, I'm focusing on kind of maybe early presentations or in the preclinical or prodromal stages of dementia, and how we might recognize those in clinical settings and why that's important. And so this is a list of just my financial disclosures. And these are the learning objectives for today that we'll kind of come back to throughout the presentation. And this is to review the spectrum of neuropsychiatric symptoms and neurocognitive disorders, to touch upon the definition of mild behavioral impairment, to evaluate and review, summarize the relationship of neuropsychiatric symptoms to multimodal biomarkers of Alzheimer's disease and related dementias, to understand how neuropsychiatric symptoms and MBI relate to the updated Alzheimer's disease staging criteria, and then finally to review challenges and approaches to recognition of early neurobehavioral syndromes. And along those lines, I didn't include a formal case, but certainly I think the last learning objective, we can transition to case discussions or questions that folks may have or have encountered in clinical practice. So just briefly, and again, I know that you all are on the front lines of this in the clinical setting, and also kind of across the professional and personal domain. So I know I'm kind of preaching to the choir here about neuropsychiatric symptoms, really extending across multiple domains of mood, altered thought process, altered impulsivity, social behavioral comportment, and really be multidimensional, ranging from mild to severe and occurring across the dementia clinical spectrum. So traditionally, kind of when we think about measuring these symptoms in older adults who may have diagnosis of dementia, who we suspect have dementia, or otherwise are not diagnosed, some of the common scales that we'll use in psychiatry and geriatric psychiatry are listed at the right. And these are a combination of kind of measuring kind of specific, again, domains of neuropsychiatric symptoms and drawing on both the individual's report as well as observation of care partners, and also some clinician observation after interviewing both patient and care partners. So again, neuropsychiatric symptoms have widespread impact in their prevalence, really across the clinical spectrum of dementia. They've been shown to be associated with disease pathology, and I'll go a little bit into kind of a summary of literature on that. And they have, again, preaching to the choir here, that they have a really profound negative implications, both on the patient and care partner's quality of life, their functionality. There's been shown to increase disease progression, increase mortality, and some of them have been shown to hasten the rate to institutionalization, or the decision to pursue institutionalization by families, and overall create a large burden on the healthcare system. And this will only continue to grow, again, as our population ages and as kind of the prevalence of these disorders as they increase. So the widespread impact of neuropsychiatric symptoms, in part, it's because we have an incomplete understanding of the biological mechanisms when they may occur in late life and preclinical and prodromal stages of dementia syndromes, and also within dementia syndromes themselves. So we have a lack of treatment option. Oftentimes we're using repurposed agents and with potential adverse side effects. Only recently have there been kind of some FDA approved medications for specific neuropsychiatric symptoms and neurocognitive disorders, but still kind of the category of tools that we have in that domain is very sparse. So again, often we are repurposing agents and don't have great ways to target these symptoms as of yet. And then especially also kind of in prodromal or preclinical stages of dementia syndromes, we kind of recognizing these symptoms and these presentations of neurocognitive disorder may present a missed opportunity to identify someone at early stages of cognitive decline, so the mild cognitive impairment stage. And that becomes more of a substantial missed opportunity when with the advent of disease-modifying therapies that could actually provide some opportunity for intervention for individuals who are identified in that early stage. So with the increasing focus on the recognition of neuropsychiatric symptoms and their importance, and also the recognition that, again, oftentimes they may occur in preclinical or prodromal stages of cognitive disorders, then the Alzheimer's Association, ISTART, Neuropsychiatric Symptoms Professional Interest Area, led by Zainer Ismail and colleagues in our working group, operationalized the term of mild behavioral impairment, or MBI. And so this was to capture neuropsychiatric symptoms that specifically may emerge in late life, so at age 50 or later, when they haven't occurred, prior to that. So when an individual may not have a kind of long-standing history of these symptoms. So they emerge in late life and they persist for 6 months or greater, and they occur in the preclinical or prodromal stages, so prior to dementia. And MBI domains, the domains of MBI were kind of are defined broadly as including decreased motivation, changes in emotional dysregulation, changes in impulse control and social appropriateness, as well as psychosis or abnormal thoughts and perceptions. And MBI, again, specifically targeting these later onset emerging and persistent symptoms, while it was operationalized and defined, the mild behavioral impairment or MBI checklist was also derived to tap into these different domains with 3 to 5 domain-specific questions. And this checklist is appropriate for use by the patient, by asking the patient directly, by asking the care partner, or by clinician report. So kind of all 3 versions are available. It's the same version, but they can be filled out by different reporters. And the neuropsychiatric inventory, or the NPIQ, which is also based on study or informant report, can also help to tap into MBI. Although again, the MPI or NPIQ isn't broken down specifically according to these domains, but symptoms can be broadly kind of grouped into these domains. So mild behavioral impairment was kind of recognized, again, with the recognition that there may be a unique constellation of symptoms in certain individuals that may emerge in later life, and really a huge amount of literature has really followed in the area of MBI, and I've included some representative studies here, but the literature is forever expanding. And basically, in one study that I highlighted from Johansson and colleagues in the BioFinder sample, which included 50 cognitively unimpaired older adults who were amyloid positive, it was found that higher tau PET signals in certain regions of the brain were associated with higher MBI C-scores, and this was independent of memory deficits. So both this particular study and a larger body of work supporting MBI as a potential early clinical manifestation that may be related to ADRD in vivo ADRD pathology. Some additional work by our group and others in the field have shown kind of, again, this association between specific MPS or MBI domains with with multimodal biomarkers of ADRD, including A beta, phosphorylated forms of tau, p-tau 181, neurofilament light, as well as some neuroimaging biomarkers related to AD, so amyloid and tau and PET specifically, and as well as patterns of regional atrophy and changes in structural and functional connectivity. Work by our group and Johansson and colleagues and others focusing on the preclinical stage, so even before the stage of mild cognitive impairment in community dwelling older adults. We've shown that depressive symptoms, apathy, and anxiety that are emerging and kind of newer onset are associated with the very earliest deposition of in vivo AD pathology using PET imaging. And furthermore, that when these symptoms are present, with concomitant AD pathology, they accelerate cognitive decline, again, in this preclinical population of community dwelling older adults. So I want to transition here, again, for the fourth learning objective, to understand how these symptoms to kind of reinforce how these are related to AD staging criteria and where they may fit in. So I've told you a little bit about the prevalence of neuropsychiatric symptoms, the definition of mild behavioral impairment, or MBI, and the growing evidence that this new onset emerging symptoms in later life that are persistent. There's growing evidence that they're associated with underlying disease biomarkers and that they may hasten cognitive decline. And so where do they fit in when we think about AD staging criteria in terms of understanding AD disease biology that have been kind of proposed by Cliff Jack and colleagues that are continuing to be revised based on the availability of biomarker characterization and how we think about disease stage. So this is a figure that on the right that many of you all may likely be familiar with in terms of thinking about Alzheimer's disease stages. So the colored lines represent different biomarkers. So the red is amyloid, and then subsequently synaptic dysfunction, tau, changes in brain structure. And then finally, the last two colored lines represent cognitive and clinical functioning. And so this just is to say, reflective of the 2011 NIA and Alzheimer's Association guidelines, which described Alzheimer's disease as occurring on a clinical continuum of a preclinical stage due to AD to mild cognitive impairment, followed by dementia due to AD. So again, the core principles here related to those working group guidelines was that AD occurs on a continuum. There's the appearance of brain pathology in asymptomatic individuals, so in cognitively unimpaired individuals, with increasing pathologic burden, increasing regional pathologic burden, and pathology spread. There's the progression of clinical syndromes. And then this last part that kind of it was introduced with this set of guidelines and continuing to be discussed with revisions of these guidelines up until today and ongoing, that the presence of the disease may be signified by in vivo abnormalities of core biomarkers. So that is to say, in a cognitively unimpaired individual, if they have certain core biomarkers, then we say there's the presence of AD pathology or AD, depending on the nomenclature that we want to use here. So since 2011, obviously the field has rapidly advanced. It's ever evolving, especially with kind of the recent explosion in recent years of fluid biomarkers that seem to closely recapitulate more expensive imaging modalities. So there's been a kind of a rapid explosion in that area, which are already making kind of biomarker characterization increasingly accessible, to broader populations, which is great in terms of our, but it's also kind of represents a steep learning curve, both in the scientific community and also in thinking about how we translate that to clinical care. So in any case, in 2022 and 2018, 2022, there were revisions of these guidelines that were based on kind of advancement of biomarker and understanding of clinical phenomenology, in a translation and an attempt to translate these biomarkers to clinical settings in 2023 and in 2024 based on based on emergence of disease modifying therapies. Although in these in the kind of recent revisions, it was specified that these guidelines did not represent clinical practice guidelines or recommendations. But in the most recent set of guidelines proposed by Jack and colleagues, again, focusing on biological staging of core 1 and core 2 biomarkers and certain core 1 biomarkers that I've listed there, which include both neuroimaging as well as CSF and plasma analytes, that these are required, or their presence is a requirement for a diagnosis of AD. And then core 2 biomarkers are not standalone tests for AD, but they can be combined with core 1 biomarkers to stage biological disease severity and the likely risk of progression in asymptomatic individuals, and also inform potentially the rate of progression in symptomatic individuals. And these are some of the biomarkers that I've listed below. So different phosphorylated epitopes of tau, as well as tau PET. And this is kind of a table from these revised 2023-2024 guidelines that show kind of the core 1 biomarkers that are required and can be standalone for diagnosis of AD or the AD pathology being present, as well as the core 2 biomarkers, again, different that signify later stages of kind of pathology progression, tau PET, different phosphorylated forms of tau. And then also are included in this table that you'll notice that these are kind of the standard ATN or amyloid tau and neurodegeneration biomarkers that are measured through imaging, as well as CSF and plasma. But also these guidelines include mention of IVNS. So that is inflammation, vascular brain injury, as well as synuclein pathology. And that these can be used, that these can signify non-specific processes involved in AD pathophysiology, as well as co-pathologies, which we're again learning through autopsy studies that are really quite common. So basically in these the staging criteria was included ATM, but also the recognition of other concomitant pathologies. And so the staging criteria was also biological staging was also integrated with clinical staging. So from stage 0, someone being asymptomatic, to stage 1, asymptomatic, but having some evidence of biomarker change, to stage 2, which I'll focus on kind of getting back to this learning objective of transitional cognitive decline, which there may be mild detectable changes, but minimal impact on daily function. And then stage 3, where there's evidence of objective cognitive impairment with early functional consequences, in stage 4 through 6, different stages of mild, moderate, or severe dementia. And just to expand a little bit on stage 2, a transitional cognitive decline, again, where we're saying that there's a mild detectable change relative to someone's baseline, but it doesn't impact their daily functioning, and where there's not objective evidence of, of their decline relative to age and sex match and education match controls in the population, but there does seem to be a change relative to their own performance. And again, there's minimal yet minimal impact on daily functioning. So again, it's a decline from their own previous cognitive or neurobehavioral functioning. And it's so interesting. And it's interesting that here, I just want to highlight, this is where kind of we have the recognition of a change in neurobehavioral functioning that is persistent, can co-occur with subjective cognitive decline. And also in the guidelines are mentioned recent changes in mood, anxiety, or motivation. So this is, although it's not explicitly kind of named here of mild behavioral impairment, this is really kind of related to stage 2 or transitional cognitive decline. And then finally, again, stage 3, 4 through 6. And then, as I mentioned, just briefly, these guidelines are continuing to evolve. And I want to just include a brief mention of this JAMA neurology paper that was also kind of highlighted at the recent CTAD meeting, in terms of what nomenclature do we want to use in the staging model. For example, in stage, when we say that someone is asymptomatic, but there's evidence of AD, a core 1 pathology or core 1 biomarker, do we say that they have Alzheimer's disease, or do they have evidence of Alzheimer's disease pathological change? And so this paper particularly argues that we really need to look at not only the biological construct, but the clinical biological construct, rather than saying to asymptomatic individuals that and telling them that you have Alzheimer's disease. So that itself can be a whole nother topic of another presentation, but I just wanted to highlight that this is kind of again, a rapidly changing space in terms of we now recognize there's a biological construct, and again, what nomenclature do we want to use to pair that with the clinical syndrome that ties in with the biology. So getting back to mild behavioral impairment and neuropsychiatric symptoms again, and before the stage of dementia. So again, we know that neuropsychiatric symptoms in multiple domains occur when someone, at the stage of MCI and beyond. They are common and become almost universal if we follow someone throughout their clinical course. But we also know, again, now there's recognition of transitional cognitive decline between preclinical and MCI stage, where also neuropsychiatric symptoms or neurobehavioral change may occur. And so a big focus of our work and kind of the field is trying to understand when these symptoms are present, what biomarkers do they correspond with? How do they predict future trajectory? How do they kind of pair with biological staging to inform us about rates of progression? And could they also allow for earlier recognition in this prodromal or preclinical stage? So finally, in kind of this last part of just the slides that I prepared, I wanted to review challenges and approaches to early recognition of mild behavioral impairment or neurobehavioral syndromes in general in the field. So in vivo, how might we recognize these symptoms, and what are some of the complexities that are involved in this? And I can imagine that there are a number of clinical scenarios and complexities that come to mind, but I'll briefly kind of highlight some points here. So again, this is the mild behavioral impairment checklist, or the MBIC, that was developed when this construct was operationalized. And these are two of the domains on the checklist related to changes in interest, motivation, and drive, which broadly may relate to apathy or changes in reward and motivational systems, as well as changes in mood and anxiety. And you can see there's specific questions related to each domain that can be asked to the individual or to a family member, or can be answered by a clinician. So if you look across these domains and the specific questions, and again, individuals or a collateral source are asked to, say if the symptom is present and how severe it might be, and then the total score is just added up across domains and across items. If you look at the specific questions here, and then you think about DSM-5 TR criteria, for example, for major depressive disorder, listed here, as well as for bipolar depression in older adults, you see some similarities here. And so I guess the question arises, how do we disentangle, what do we use, and how do we disentangle someone who is coming in with these symptoms? And could it be a psychiatric condition? Could it be mild behavioral impairment? What nomenclature do we use? Or how do we think about this? So that's one of the complexities that can arise. And so indeed, the question is this an important dichotomy? So for example, in some ways we're talking about nomenclature here, like how do we want to characterize these symptoms? And I'll get a little bit into that in some future slides, but also another way to think about it is, again, when thinking about these symptoms as emerging and kind of new onset and persistent in later life, in this prodromal stage, preclinical or prodromal stage of a dementia syndrome, that being potentially one presentation. And then also thinking about individuals who might age with psychiatric illness, who, for example, who might have major depression, bipolar disorder, anxiety disorders diagnosed in early life and have recurrent episodes as they age. And then again, these symptoms may persist through the stage of dementia. So I've just listed some studies here to highlight that in my clinical research program, and more broadly in my colleagues and larger research group, and just within the Alzheimer's Association, Neuropsychiatric Symptoms, PIA in general, we're really tackling this from all directions. So for studies such as the Alzheimer's Disease Neuroimaging Initiative and the National Alzheimer's Coordinating Centers through the ADRCs or NAC, we're able to try to investigate this question using samples that represent, again, both preclinical as well as individuals who are in the clinical stages of dementia. And there's some of the work, our local work in Boston. We've utilized the Harvard Aging Brain Study and some other cohorts that I will tell you about to investigate community dwelling older adults who are really, for the most part, free of pre-morbid psychiatric illness, who we follow over time up to 10 to 15 years, and in some whom we see an emergence of kind of, again, newer onset symptoms that we've been able to correlate with early biomarker changes. And then lastly, my own interest as a geriatric psychiatrist, given the patients that I may encounter, are those who have aged with psychiatric illness. So particularly the mood and memory and aging study is a study, or the MOMENT study is a study that I've begun in parallel to the Harvard Aging Brain Study, which focuses on individuals who are diagnosed early in life before the age of 50 with recurrent depression, and asking whether or not, how do they have an increased biomarker load, or if we're given a set of biomarkers, are they more vulnerable to cognitive decline? So, so that's kind of the full spectrum of how our group and the larger field are kind of investigating this question. So I won't go into some of our more specific related, findings related to these different research studies, but I'll just mention here in terms of, in a clinical setting, what might be that are red flags of thinking about, that this is a newer onset or persistent syndrome, which is, again, more likely to be associated with biomarker changes, especially if it's a kind of an atypical presentation or a first presentation late in life. So again, the importance, I think, would be representing a change from an individual's baseline. So, so for example, even if someone has a prior diagnosis of a psychiatric condition, that somehow their clinical presentation is changed, or not maybe the presentation they've come in with earlier life. Maybe now there's more marked anxiety or apathy that's noted. There might be more marked impulsivity. This may be maybe comorbid with cognitive concerns. So, so there's some type of change, even in those who have aged with psychiatric illness, or this might be, again, the first such presentation that someone's had. Also, kind of being aware of neuropsychiatric presentations that are somewhat atypical, what we might think of kind of standard syndromes. So for example, in the case of obsessions that are non-ego dystonic, compulsions that occur outside of obsessions, loss of empathy, emotional detachment, lack of distress. So really the individual having experiencing these symptoms, but themselves maybe not being aware of them. Really this being reported or observed more by a family member, or even you as the clinician. These symptoms kind of being sustained. They're being associated with concomitant cognitive changes, maybe in specific or multiple domains, and that there being potentially like a lack of treatment response to typical first-line pharmacological or behavioral approaches to treat symptoms like depression or anxiety, or that there may be an atypical response to agents such as these. For example, if there's any evidence of motor neuron signs on disease or Parkinsonism on exam. And then also finally, if there's a family history of frontotemporal dementia or another dementia, all of these things can kind of raise the suspicion of, is this a primary psychiatric versus a prodromal representation of a neurocognitive disorder, versus are both occurring. And also, just to be aware, in some cases, the psychiatric symptoms actually may be more typical, and really the only clue may be that the age of onset, again, this might be a first presentation late in life that might, again, kind of raise one of those red flags to ask more about, family psychiatric history or family history of dementia syndrome. So, but again, some of the presentations could still seem somewhat typical when we look at, DSM-5 criteria. Some key principles of assessment then would be, I think I've already highlighted some of these medical and neuropsychiatric, both report of the history obtained from the patient and also a family member, focusing on onset and persistence of the symptoms, medication responses, concomitant substance use, vascular risk factors, family history, physical and neurological exam findings, as well as clinical assessments using some of the tools that I've mentioned. And I also want to highlight here that that the important kind of some nuances in terms of assessment, that a care partner-based history is essential. So even in individuals in whom we're not suspecting mild cognitive impairment or dementia, it's important to obtain at some point an independent report from someone who knows the patient outside of that particular clinical setting. It's also important, again, this could be a subject of a whole talk in itself, but just to consider the cultural context of how these symptoms, how you're asking about these symptoms and how the symptoms are reported by patients and family partners. And then future work in this area, they also get a kind of more objective assessments of emotional behavioral function that could try to decrease some of this complexity of self-reporting versus family reporting versus observation and some of the biases that might be involved. Just to highlight the importance of study partner or care partner report of symptoms. So this is a study from the Harvard Aging Brain Study. I'm sorry, this is an analysis from the Harvard Aging Brain Study, or HABS, that I carried out with a very talented research coordinator in our study, Jessa Burling, who was interested in neuropsychiatric symptoms. So in HABS, just to give you some context, this is a sample of about 160 individuals in HABS who are 65 or and above, who have been followed for up to 1 to 10 years. And they enter the study being cognitively unimpaired. The individuals in purple are the ones that through the course of the study, they progress to mild cognitive impairment. So in this particular analysis, we wanted to look at apathy across the entire sample in relation to PET biomarkers, so amyloid and tau PET in early regions of deposition. And we found actually a discrepancy between study partner versus self-report, even at this very kind of early normal stage. So it is in utilizing study partner report, but not self-report, we found that greater apathy was significantly associated with amyloid and tau pathology. And again, we did not see that association in self-report. And this is in a predominantly cognitively normal cohort. So that was very interesting to us. And again, we did some further sub-analyses where we looked at this, excluding the MCI participants. The MCI participants seemed to be the ones who are driving it. But even within the cognitively normal, the results seemed to be driven by the cognitively normal that had A beta pathology, who were kind of in the stage 0 or stage 1. So again, the big picture here is just get a collateral report when asking about neurobehavioral functioning, even if you don't have suspicion of someone having dementia or impaired cognition. A further nuance is, again, as I mentioned, in different cultural groups. So in collaboration with colleagues in the Multicultural Alzheimer's Prevention Program, Dr. Yakel Kuroz, and this work that was led by Jorge Alsina, Dr. Jorge Alsina, we started to look at mild behavioral impairment checklist in a community dwelling cohort of Latinos in Boston, or BLAST. In this particular study, this was based on a community registry study. We don't yet have ATN and vivo biomarkers, but we did find that the apathy-related domain of the mild behavioral impairment checklist was related to to cognitive performance in these individuals by self-report, and we didn't find an association with the mood and anxiety domain in their cognitive functioning. So that was interesting to us. We have, in this particular sample, we've only looked at self-report, but now, of course, we will also want to examine whether or not in Boston community dwelling Latinos, if there's a discrepancy between self versus care partner report in reporting these early neurobehavioral symptoms in relation to cognitive change and biomarkers. So again, thinking about, is this an important dichotomy to think about whether or not, if neuropsychiatric symptoms are occurring in late life, is this part of a preclinical or prodromal stage of a dementia syndrome? So kind of some ways to think about it is that in some cases, so these symptoms or these changes may emerge and they're related to an underlying neurodegenerative process, and there may be psychological reactions, super and character traits also present and contributing to their presentation. On the other hand, someone coming in with an older adult with psychiatric symptom presentation, they may have aged with a psychiatric. This may be a primary psychiatric disorder. There may not be the presence of underlying biomarker or neurodegenerative change. So in this case, we think of this as a psychiatric, we think about this as a primary psychiatric presentation. However, this group is still is vulnerable. And in fact, both things may be occurring, as alluded to earlier. So someone who has aged with psychiatric illness and who also has a concomitant MBI syndrome. So that's something I always I always try to emphasize to my colleagues that just because we say like, okay, this person, they've had depression throughout their life, so we shouldn't, be concerned about them because obviously they're still depressed and they're concerned about their cognition, but early onset recurrent depression is an independent risk factor for all cause dementia. So actually we should be following those individuals very, very closely. And we're hoping, or at least my group in the larger fields work, we're hoping that we could develop clinical tools in combination with biomarkers to pinpoint who are actually at the greatest degree of risk when they're coming in clinically, rather than saying, let's just closely follow you over time if you're presenting with these symptoms. And so again, recognizing myobehavioral impairment, early neuropsychiatric symptoms has implications for early detection, accurate diagnosis, management and prognosis and patient and care counseling, as well as overall quality of life. So even in early stages, recognizing and attempting to intervene or educate patients and care partners can make a huge difference. So for example, in the case of apathy, we may not think that that's necessarily as disruptive, but it can be it can really cause dyadic frustrations between patients and families if families don't recognize that as a symptom of an underlying neurodegenerative condition and think about it as being more of a volitional kind of behavior or lack of behavior. Like this person just doesn't want to do anything. They're just sitting there all day. So this recognition and this intervention can have a big part of just improving quality of life, even with even without having specific agents that we could use to treat these symptoms. So I'm just going to stop there in terms of, I think I've summarized some of these key points here, just kind of going through, touching on the learning objectives, and then, just follow up questions for the field. We need better diagnostic criteria for psychiatric symptoms in the context of degenerative conditions. And then we need to kind of understand how these symptoms, again, may or may not change relationships of biomarkers to cognitive symptom progression. And then also just the key question, if we treat these symptoms, can we, again, prevent dementia or slow cognitive decline, which is still very much an open question. So, I will stop there and just thank the group of colleagues at the Harvard Age and Brain Study, the MOMENT Study, Mass General, McLean, and then funding sources and mentors and all of the patients and care partners who have dedicated so much time to these studies. And just to thank all of you, because you are on the front lines of kind of recognizing and treating and managing these clinical syndromes. So thank you for all of your work that you're doing for patients and families to do that. So again, this is my email address if you have any questions beyond today. So.
Outstanding. Thank you so much. That was a very thorough overview of both the underpinnings and clinical features and future directions. I'm sure there's lots of questions. We've got plenty of time for a great discussion. So I'm going to open it up for the community, our hub team to kick it off. Kathy, yeah, go right ahead.
So keep in mind, I'm a social worker, so some of that was a little higher for me. But my question is, when we're seeing some of these attributes and things, do you think mindfulness and doing some practical training like that and trying to help people with anxiety, would that help them maybe, keep the symptoms from moving forward or help the symptoms at all?
Yeah, that's a great question. And I think that's something that I grapple with quite a bit just in the clinical practice. I do think that those approaches, really, I think that they can be among the first line approaches, to try, because we don't have great evidence, or really don't have any evidence that, for example, if someone's presenting with anxiety, irritability, maybe concomitant with like their recognition of cognitive changes, we don't have great evidence that standard SSRI is going to be helpful in that situation. So really, in those situations, I might try a pharmacological intervention, but kind of counseling the patient, we don't have evidence. And so particularly kind of the approaches that you suggested, I think could be really helpful. And particularly if there are ones that are, I know they're kind of have general mindfulness, general CBT and things like that. But the question is like, can we, I don't know what your experience is in the field kind of in these types of scenarios, like how can that be tailored? Could that be tailored specifically to maybe kind of this type of presentation?
And that's kind of, I work at Albert Medical Center. We have a gero psych unit, And we get a lot of, and it's specifically for persons living with dementia who aren't making it into the community. And that's one of the things I'm trying to kind of get in there a little more, because I would like to try to start doing some of that. Let's start doing some breathing. When I have been up there and some patients have started to get upset, I try to help them do that, and it does help calm a little bit. So I think that's an area that really would be really good to continue to research and then just really try to implement. And I'm just trying to do my own little experiential, like, hey, this is my experience, so let's try it type thing.
No, absolutely, absolutely. And I think that really, yeah, that's really, I think the best first line approach is to try some of these behavioral interventions, and the more that we can find ones that are particularly effective or that can be kind of adapted or taken up by particular patients, that they'll enjoy. And so like things like, I like your approach of like physical or kind of somatic interventions or breathing, because maybe there's not a degree of, cognitive reserve that might be needed for that might be acceptable by a number of individuals. So yeah, that's great. Thank you. And Barack?
Yeah, thank you so much. That was so detailed and great. And I think the thing that we all struggle with, I know you struggle with too, is just how to decide when to try an SSRI. Like how to predict when do we think somebody might respond. Just making a diagnosis of depression in somebody who has dementia and MCI as well is just so tricky. Like a PHQ-9 is just so much less useful because of the overlap of the symptoms, just like you were saying. So do you have like what are the kind of practical tips that you use to decide, oh, I think this person really, might have depression and might respond to an SSRI?
Yeah, it's a great question, because that's absolutely right. I mean, I'm actually thinking of a specific patient who I've just started seeing now, and she doesn't it doesn't clearly fit kind of the DSM-5 TR, criteria of depression, but she's reporting, the family reporting kind of significant distress, like outside of the context of the setting. There's a degree of an adjustment disorder. So I would say, I think if they're, even if someone's not formally meeting criteria of like major depressive disorder, if I'm suspecting like depressive disorder, NOS, or even adjustment disorder with depressed or anxious mood, something along those spectrums. And then again, this is even if that's obtained not only through interview of the patient, but through extrapolating information from their family interviews and such, that I may counsel them as, an SSRI might be among the options that could be helpful. Both the caveats that we were just talking about with Kathy, that there isn't strong evidence for this, and that we should try like more of like an overall holistic approach. So kind of counseling about the risks and benefits, and then
so when do you suspect those things though? Like what does lead you to suspect those conditions?
Oh, conditions. Do you mean conditions like an adjustment disorder with anxious mood? Or I think I still rely on using MBI criteria as well as DSM-5 criteria, so a TR criteria. So again, when do I suspect? I think I'll just, yeah, if kind of they're meeting criteria across these disorders, even if it's not strictly clearly like severe recurrent MDD. Does that answer your question? So even if I'm coding it as depressive disorder NOS, if I'm saying, okay, they meet that criteria, they meet criteria for a syndrome, even if it's adjustment disorder with depressed mood, I would consider, suggesting as a possibility to them at that stage. If there was degree of patient distress, if they're just like, fine, the family's fine, then I wouldn't necessarily introduce it as an option. I don't know if that answers your question.
I have a kind of a related question that I see Sylvia has a hand up too. I'm trying to remember the paper. It came out last year looking at cholinesterase inhibitors for neuropsychiatric symptoms. I think it was like New England Journal. And I don't know if there are times where you think, ooh, maybe these are sequelae of a dementia, therefore we're going to maybe lean that way versus an SSRI or other things. Your thoughts about that?
Yeah, no, definitely. And that's a great point. So in the patient that I was just thinking of as well, who was in like early stages of cognitive decline and multifactorial, not clear if it's due to AD or multiple etiologies. I think, having the conversation about a cholinesterase inhibitor as well as a SSRI as kind of approaches at that point. I think, at that point, kind of having more information about like in terms of neuropsychological testing. So they actually like in the meeting criteria for mild cognitive impairment, that's when I might, kind of think about SSRI versus cholinesterase inhibitors. But in terms of someone being the subjective cognitive decline stage, I wouldn't necessarily think of a cholinesterase inhibitor at that point. I myself would. I don't have a large degree of clinical experience or success doing that, but I have not prescribed cholinesterase inhibitors in that setting. But I'm aware of colleagues have and patients who come to me definitely who are on cholinesterase inhibitors. But yeah, so that's my thought about. Sylvia?
Yes, thank you. So I have a question regarding actually one of my most difficult patients. And what I believe is this patient is 80 years old, and he came to me with what really seems like delusional disorder, where he thinks somebody joined forces with his wife and drugged him and mugged him, and he's very convinced of this. And it really sounds like some of those young people with delusional disorder. He has some cognitive impairment and he has some atrophy and vascular disease in his brain. So I do suspect this is actually an atypical presentation of Alzheimer's disease. And I don't know if you've probably seen this more in your practice than me as a neurologist, but strong refusal to take medications or to follow up or to even acknowledge that there may be a problem and trying to get to him in any way possible, but it's really difficult. And so I don't know if you have any practical advice on what to do, because if we do nothing, he's just going to progress and he's going to lose his independence. And trying to slow that down, how do you work around it?
Yeah, it's really challenging. I mean, I think so delusional disorders, even out of the context of, being like early presentations of, it sounds like you're suspecting AD or related dementia. Is that right? Yeah.
Sorry, I muted myself. Yes, I think so. I think it's probably a dementia.
Yeah, so even out of the context of dementia, so like you mentioned, in younger life delusion, they're among the most, like the most challenging syndromes to treat in psychiatry. So it's largely because of what you mentioned, that there's maybe lack of insight. There's lack of insight. There's really little collaboration or desire to take medication, kind of seeing that it's not problematic. Why should I take medication? So in this particular case, I might align, I don't know what the kind of family situation, psychosocial situation is, but I might delve a little bit more into that. And then I also might kind of pursue this more from the direction of the cognitive change. So he may be more, I don't know if he or she may be more amenable to kind of reviewing the cognitive profile and kind of maybe the workup for the dementia syndrome and kind of approaching it from that direction and kind of saying, I think this is kind of what's going on. I think this is the underlying diagnosis. And so I'm concerned about progression, of these cognitive symptoms. And, it could be the case that, and then kind of starting with that approach and then maybe trying to then layer, if there's kind of receptivity there as a next step, to layer on kind of the delusional component and kind of wondering, with the patient, like, this oftentimes is like a related symptom. So I might try that approach, because I have to say, like, for kind of what you're describing is really just kind of almost like, just approaching it from like challenging the delusion. Really, it's really impossible. The other approach would be, like I said, if you have an alliance with a family member and if he's kind of recognizing distress that this might be causing to them, sometimes that's not the case at early stages, but yeah, I might try kind of patient family counseling and just counseling about a larger syndrome and how you're concerned about this progressing. And yeah, even if he's not going to amenable to treatment for the delusion at that point, at least there's some kind of recognition and planning of what might be happening.
Thank you so much.
Thank you.
I know this way, I know I'm not alone, or I'm not doing
You're
something
not alone.
wrong.
It's really tough. It's really challenging. Yeah.
Thank you.
Yeah. Oh, and thank you, Dr. Rhodes. I see you put in the chat the clinician for psychotic symptoms. Oh, interesting. Yes.
Yeah. The effect sizes are not huge, but it was an interesting meta-analysis. It was in JAMA Neurology. The commentary was on the New England Journal. But related question is, people think about this. The other place that I have seen some benefit for kind of MBI, especially around the apathy and demotivational syndrome, is working with speech and language pathologists and more of a cognitive rehab model for like scheduling and prompting and kind of queuing and helping families do that. I don't know your thoughts or experience there.
Yeah, I definitely agree. And I think I was maybe broadly thinking about it when I was thinking of like behavioral interventions. But I know that's kind of a distinct, aspect of non-pharmacological interventions, but I think that that's very can be very helpful as among kind of the first line approaches for, like you mentioned, for apathy, for that type of like scheduling. I think is can be very helpful. So I think there's definitely a role for OT, speech and language pathology, and targeting some of these symptoms. And I know there's also some clinical investigation, the clinical investigation stage, but some positive clinical research trials on the role of stimulants for apathy. And then I think some emerging research looking at stimulants combined with neuromodulation for apathy. But I don't think that's kind of part of current first line, maybe like standard of care as of yet. So I think what you're describing is among kind of the first line approaches. Yeah. And Karen?
Yeah, hi everybody. Speaking as the caregiver role, a comment and then a question. When I started realizing my husband probably shouldn't be going to his medical appointments without me, questioning his ability to take in, understand information, and then make reasonable decisions about that. So I started going to both his primary care provider visits, and by that point, he also had a neurologist. And I'd say I felt particularly unwelcome by both providers. Like, what are you doing here? Because Scott could appear rational and until he was a physician himself, and to the untrained eye, maybe appear more happening than he was.
Yeah.
And so that was a particularly distressing experience for me, because then I didn't have any standing with my husband to bring up issues. I appreciated on your slides where you said, get perspectives from the spouse or other family members. So that leads to my question, which was, I'll just say, when I went to memory and brain wellness at Harborview, and one of their requirements was that the caregiver accompany the diagnosed person to the thing. I thought that's it. I hadn't really been analyzing it, but I realized, this is what I was experiencing, and these people get it. And I was super happy to see that as part of their care model. So my question is, when you talk about, or Sylvia's example of this gentleman she just mentioned, bringing the family in on discussions, how do you get permission from the husband, or my case husband, the family member who's your patient, to have that discussion, especially if they're being very reticent and not admitting they have a problem, or apparently this wife had connived with other people to mug him and so forth. So how do you approach that so you don't break HIPAA and that you don't disrespect the client's ability to consent to that?
Right. No, absolutely. And those are great points. And not only for just obviously HIPAA, but just patient alliance and kind of the management program. And so, I guess when I mentioned on my slide, I wanted to emphasize the importance that we've observed of care partner report, but I didn't mean to be so prescriptive that like call the care partner on the first visit, no matter what, although it may have come across that way. But definitely, yes, what you would need the patient's permission if you believe they have capacity and are not at acute risk of harm to themselves or others. So it's a great question. I think that I think all this kind of gets at the question of dementia screening in primary care settings, and basically, I've seen different. There are different instruments that are used for this. They're like dementia warning signs in the VA system, and so many times like these screeners may be filled out by the patient and the family. So that's one way to kind of obtain, kind of family input even without saying, can I contact, so again, and I think that's not kind of standard practice. It's greatly variable, like from clinical system to clinical system, if that's done or not, so, and I think right now it's also kind of largely dependent on if the family member's coming in, rather than those aren't things that are directly sent to like the family if they don't come in. So it's a great question. So I think, yeah, so definitely you definitely, need the patient's permission. And I think I think just kind of forming an alliance with the patient, before kind of saying, I want to like hear someone else's report about you, but just, I would say kind of through the process of building the alliance, even if it's not in the first visit, to kind of introduce the concept, as part of my practice, I like to provide holistic care. And, we know that kind of stress management is going to be really important, and brain health for your condition. And so it's important to have the buy-in of your family for that too. And they can kind of, if it doesn't, even if it's not your family, someone who's in your life, and kind of trying to get that buy-in. So that can be one way to approach it if there is this reluctance. Sometimes it's hard because, individuals may not have family, or they may not have someone close to them, or have had a loss, and so in those cases, sometimes, asking if they have other clinicians that they're working with, or even other like therapists, and also, getting their permission to collaborate with the clinical team to see like, what is someone observing at their visit? Is this person coming in disheveled? Are they being able to adhere with the treatment plan? Or, just kind of collaborating with the clinical team if you're not going to have any access, or that's not going to be accessible. And further, I'll just kind of mention there's also the culture, obviously the cultural context here too is incredibly complex, right? Because across different cultures, it may kind of be perceived or not recognized that behavioral changes are part of, a cognitive disorder or dementia, or like a warning sign. And this may be perceived as like, this is just part of, aging, or this is just like what happened. So I think there needs to be kind of a recognition of that, and kind of a gradual introduction of how you might discuss these symptoms or changes with patients and families. Yeah. So that was pretty long-winded. I'm sorry about that.
No. All excellent information. And Barack, I see you put your hand down, Matt, maybe out of respect for time. I appreciate that. We are at time. I'm going to do one last share here just to give you a highlight of what's coming up next. Thank you so much, Dr. Goetz. So our next session, our last session of the year, recall that we only have one in November and only one in December. Next session, Friday the 13th, what could go wrong? I will have the great good fortune of co-presenting with Paige Ulrey, some of you may recall, who's our senior deputy prosecuting attorney here in King County for elder abuse, and Dr. Messier, our geriatric fellow at Swedish. We have all been involved in a case involving financial abuse. So we will talk about financial capacity as the didactic, and then we will have a case, that very case, to cover. So should prove to be quite interesting, and I'm looking forward to it. And Dr. Russo, I just saw your email, so that will be particularly relevant for you, perhaps, but I'll respond to you.
Thank you. I really appreciate any help.
Yeah, all right. Thank you all for coming, and have a wonderful rest of your day, weekend with soup and the woods and all those other things, trees. All right.
Thank you. Bye.
And Dr. Gatcher, thank you again.